Welcome, everyone. We're going to go ahead and get started. Thank you so much for joining us today. I'm going to turn the session over to Mary Naylor, the Program Director for the INQRI program.
Good morning or afternoon to all, and welcome to the second in a series of webinars that are being sponsored by the Robert Wood Johnson Foundation-funded Interdisciplinary Nursing Quality Research Initiative we finally call INQRI. And on behalf of Mark Pauley, who is our co-director, Lori Melikar, Senior Program Officer at the Foundation, and Heather Kelly, who is our Program Associate and the glue that holds all of this together, I want to welcome you to the second webinar in the series that are focused on the implementation of the Institute of Medicine recommendations related to the future of nursing. Today, we're going to focus attention on the fourth recommendation to increase the proportion of nurses with a baccalaureate degree to 80% by 2020. As you know, I'm all in this audience, and we have about 100 participants today from a wide range of stakeholder groups. There are many issues surrounding the successful implementation of all of the recommendations. To discuss implications of this specific recommendations, we are delighted to welcome today Maja Djukic, who will present on differences in quality improvement participation seen in associate and baccalaureate or bachelor degree graduates. Maja is an assistant professor at the NYU College of Nursing, where she was a Mary Clark Rockefeller doctoral fellow. In her research, her line of inquiry, she studies impact of the social and physical aspects of nurse practice environment on nurse work outcomes, on patient outcomes, quality and safety of patient care delivery. Additionally, she's very interested in generating interventions that translate research knowledge to have real meaning in clinical practice for those directly at the bedside and for their leaders. Currently, Maja is the principal investigator on a study funded by the National Council of State Boards of Nursing Center for Regulatory Excellence and is examining practice role expectations and educational preparation related to quality improvement and patient safety for entry-level RNs across 15 states. So you can see she's extraordinarily well positioned to talk on this topic. She's also a co-investigator on a Robert Wood Johnson funded RN work project examining career trajectories of newly licensed registered nurses over a 10-year period. As co-principal investigator on a Josiah Macy Foundation, and I found this to be really exciting work as well. A project that she's working on is NYU 3T, Teaching, Technology, and Teamwork, where she's collaborating with School of Medicine faculty at NYU to develop, implement, and evaluate a curriculum aimed at improving teamwork competencies of future nurses and physicians. And as part of this effort, she's also involved in teaching undergraduate nursing students those critical competencies of teamwork and quality improvement, patient safety, and cultural competence using high-fidelity simulation and other technology-enhanced teaching strategies. So we are just thrilled, delighted that you're able to join us today, Maja, and ask that you take it away.
Thank you for inviting me to present and for the kind introductions. So welcome, everyone, and I'm happy to share with you the findings of several of our studies that looked at differences between associate and baccalaureate degree nurse graduates, both in their perceptions of QR preparedness as well as their participation in quality improvement at work. And we will also present, or I will present, analysis that we have recently completed looking at predictors of educational progression for newly licensed nurses in our sample. Before I continue, I would like to acknowledge funding from the Robert Wood Johnson Foundation and the National Council of State Boards of Nursing Center for Regulatory Excellence for the work that we do, and also our incredibly fun research teams from the RWJ-funded RN Work project, particularly Dr. Christine Kovner, who is the principal investigator for that project here at the NYU College of Nursing, and Dr. Carol Brewer at the University of Buffalo. So we all know that there is some research suggesting that higher educational attainment can lead to improved healthcare quality for specific patient populations. Those have been mainly studied in hospital settings for surgical patients, and this evidence was informed by work of Dr. Linda Aiken, Christopher Fries, and Eileen Lake from the Time University of Pennsylvania, and a number of researchers from Canada, Dr. Carol Estebrooks and her team. Building off of this evidence, as well as increasing complexity in our healthcare system and the role that we want nurses to take in coordinating care and meeting the needs of increasingly complex healthcare populations, the Future of Nursing, the IM Future of Nursing Initiative has made several recommendations that specifically they have expressed in key message number 2, that nurses should achieve higher levels of education and training, and then recommendation number 4, to increase the number of baccalaureate prepared nurses in the United States to 80% from current levels of about 50% by 2020. We have looked at the National Sample Survey of Registered Nurses and have done quick analysis comparing the 1988 to 2008 data to examine current trends in educational attainment for nurses. And what we have found, there are actually some positive trends. So if you look at 1988 to 2008 comparison for basic nursing degree, we have actually seen about a 30% drop in diploma graduates and about 15% increase in the number of nurses whose first basic degree is an associate degree, and also about 12% increase for the first basic nursing degree for baccalaureate graduates. If we look at the highest nursing degree, also comparing the 1988 to 2008 data, we see similar decrease in the total number of diploma nurses who have a diploma degree, about 27% drop, and then increase of about 10% for associate degree nurses overall, and 10% increase for baccalaureate degrees. So if we combine the total percent of nurses in 2008 who have baccalaureate or higher degree, we see that currently that's about 50%. Moving on, the questions that we wanted to answer in our research that I will be presenting today, although we see these positive trends in number of nurses who are obtaining baccalaureate degree increasing over the last 20 years, we don't know a lot about what factors predict nurses obtaining additional degree. So I will discuss our findings in the second part of this presentation. And then there is this evidence that suggests that higher education is related to, for registered nurses, to positive patient outcomes for some patient populations, but we don't know a lot about what exactly is it about this higher education that can potentially be contributing to nurses being able to provide higher quality care. So we wanted to look specifically at differences between associate and baccalaureate prepared nurses and look specifically in their quality improvement competencies, as well as their participation in quality improvement activities in work setting, to begin to uncover what specifically about additional education contributes potentially to better patient care. So in this presentation, I will first discuss these differences in quality improvement preparedness and participation, and then describe factors related to RNs pursuing additional education. We use several data sources to answer these questions. For the quality improvement comparisons, we looked at two data sources. One is our 0405 sample of nurses from 35 states and District of Columbia, which is a subset of our longitudinal cohort of nurses, which we will be following for 10 years, and that's the study funded by the Robert Wood Johnson Foundation. And the study funded by the National Council of State Boards of Nursing, I have replicated this analysis in a separate cohort of newly licensed nurses, those who were licensed in 07 and 08. For our educational and progression analyses, we have used the longitudinal cohort sampled and in those nurses who answered to the first 3 waves of our data collection, and I will discuss this a little bit further on. For the quality improvement comparison, we use cross-sectional comparative analysis, and again, we had 2 cohorts of newly licensed nurses. First, those licensed between August 1 of 2004 and July 31st of 2005. And the second cohort were licensees in 07-08. Both of our samples, we selected those nurses who worked in hospitals only. For our original 04-05 licensees, we sampled nurses from 51 metropolitan areas and 9 rural areas. And for this sample, we have replicated the analysis done by the Center for Studying Health System Change for their community tracking survey study, in which they randomly selected these 60 sites across the United States, and then within those 60 sites, we randomly selected newly licensed nurses for each site. We have only examined for 07-08 licensees nurses in 27 areas, because those were the sites that were able to give us perfect lists of newly licensed nurses licensed by exam for the first time, only to decrease the cost of survey administration. We mailed out an 8-page survey using Dillman-Taylor design methodology with repeated contacts to non-responders. And our questions were organized into 4 groups. We asked questions about basic nursing education. We had 25 questions on different topics related to quality improvement and other quality and safety competencies. And then we had 10 questions about participation in quality improvement at work. We define quality improvement as use of data to monitor outcomes of care processes and use of improvement methods to design and test changes to continuously improve the quality and safety of healthcare systems, which is consistent with the work that is done and initiated by another RWJ project, QSEN, Quality and Safety Education for Nurses. In terms of our analysis, we used Fisher exact chi-square test for categorical variables and independent sample t-test for non-categorical variables and Bond-Ferroni correction for post-hoc analysis, and we set our significance level at p less than 0.05. These are the results describing our samples. There's no big surprises there. They're mainly female, white, and about 50% in both cohorts were married. You can see that for associate degree graduates for both cohorts, they're a little bit older than the baccalaureate degree graduates, with the mean age for associate degree at 36 and for baccalaureates at about 30. In terms of the first basic degree, we see similar trends. For 04-05 licensees, about 55% had associate degree, and about 44% had baccalaureate degree as their first basic nursing degree. Again, about 30% in both cohorts worked in medical surgical units, with and about 20% in intensive care units. These are the results for 04-05 licensees. In summary, baccalaureate RNs reported being better prepared than associate degree RNs in many of the quality and safety measures that we looked at. So if you see the first 2 are teamwork and collaboration and evidence-based practice, then the rest of the items really focus on different components and steps in quality improvement, including data collection, data analysis, measurement, project implementation, using QI data analysis or project monitoring tools, etc. So these are the summary of findings, and in the next several slides, we just look more closely at findings for each of these items. So baccalaureate degree RNs reported being better prepared for teamwork, and in post-hoc analysis, we saw that the statistical significant differences were for baccalaureate being better, reported being very prepared compared to not at all prepared, compared to associate degree graduates. Baccalaureate degree RNs also reported being better prepared for evidence-based practice, and specifically in categories very prepared compared to somewhat and not at all prepared, again, in comparison to associate degree graduates. The same was the case for assessing gaps in current practice. And this is another summary of the additional quality improvement skills which I summarized in the previous slides. And I'll be happy to go back in discussion section and review these in more detail. And these will also be available for you to review additionally if need be. Associate degree registered nurses reported being better prepared than baccalaureate degree nurses in using appropriate information technology or strategies to reduce reliance on memory. So this was the only item for which associate degree RNs reported being better prepared. And then, interestingly, despite differences in their perceptions of educational and preparedness, when we compared differences in their reported participation in quality improvement activities at work, we did not find any differences between baccalaureate and associate degree graduates at the 0.05 level. For 0708 licensees, we also noticed similar trend. Baccalaureate degree nurses were better prepared in a little bit less of the categories, evidence-based practice, and then for quality improvement activities, data collection, data analysis, measurement, and assessment of gaps in current practice. More baccalaureate prepared RNs than associate prepared RNs reported being very prepared compared to somewhat prepared. And more baccalaureate prepared RNs than associate prepared degree RNs reported being somewhat prepared compared to not at all prepared. I mean, just to stop for a minute, we see that across both associate and baccalaureate degree graduates, we have only about 30% reported being very prepared in both groups. For data analysis, measurement, and assessment of gaps in current practice, we also found that baccalaureate degree RNs reported being better prepared and specifically being very prepared compared to not at all prepared. Now moving on to participation in quality improvement activities at work for 0708 cohort, we saw, unlike in 0405 cohort, that there were differences in participation in quality improvement between baccalaureate and associate degree graduates. And in the following way, more baccalaureate RNs reported assessing gaps in current practice than associate degree RNs. However, more associate degree RNs reported applying QI tools and methods compared to baccalaureate degree RNs, although they reported being less educationally prepared, they were more likely to participate in these activities in their work settings. Again, more associate degree RNs participated in repeating quality improvement steps that for sustained quality improvement compared to baccalaureate degree RNs. And I guess that was the last slide in the quality improvement comparisons, and we'll come back to discuss the implications of these findings at the end of the presentation. So now moving on to examining factors that predict educational progression. We looked at the first three waves of our longitudinal panel. So those were the 04-05 licensees who also responded to our surveys in 2007 and 2009. We had about 1,500 registered nurses who responded to all three waves of data collection. The goal of our analysis was to determine what personal characteristics, work attributes, and attitudes at waves 1 and 2 predicted RNs being enrolled in or completing a higher degree in nursing by wave 3. To answer this question, we used logistic regression analysis, and we set our significance level here at 0.10. We performed 2 regression analyses for each AD and BS groups. So we looked at predictors of completing a higher degree at time 3 and also predictors of completing or being enrolled in a higher degree program at time 3. We included a number of regression variables in our models based on the literature in nursing and both outside of nursing on what predicts educational progression. So we had a number of personal characteristics which really employers or policymakers can do very little about. And then we included work attributes and attitudes that were significant based on a comparison that we performed for those people who obtained degree and didn't obtain degree at time 3. We compared them on a total of 22 work attributes and attitudes using based on t-test analysis, and these 6 were significant and were included in regression analysis. In terms of our sample, we had, again, mainly white nurses. We see that higher percent of nurses whose first basic nursing degree is associate degree were married, and they were again older than the baccalaureate graduates. Majority of them worked on general medical surgical units, followed by ICU or step-down units, and then a number of other units, which included specialty mainly units, emergency room, operating room, recovery, labor, delivery, etc. We see here similar trend. About 59% of our sample had an associate degree. This was at wave 3, and about 41% had a baccalaureate degree at wave 3. Looking at the results of the regression analysis, which looked at those nurses who at wave 1 had associate degree and then by wave 3 have completed a baccalaureate degree. Black nurses, those who were not married, who had more positive affectivity, who resided in rural areas, had previous non-healthcare work experience, worked in ICU or step-down unit, and worked a day shift, were more likely by time 3 to obtain a baccalaureate degree. Similarly, those nurses who were younger, Black, had more positive affectivity, had previous non-healthcare work experience, worked a day shift, and had higher work motivation, were more likely by wave 3 to either complete or be enrolled in a baccalaureate program. For those nurses who at time 1 had a baccalaureate degree and who completed a master's degree or higher by time 3, those who were Black, had previous non-healthcare work experience, held more than one job for pay, had a higher total yearly income from secondary and other jobs, and who had lower intent to stay at their current job and a higher variety in their current job were more likely to obtain a master's degree by wave 3. Similarly, this is the same analysis, but we also included those who not only completed but were enrolled in a master's or a higher program at time 3. Those who lived in non-rural areas, worked a day shift, had more voluntary overtime, and reported more variety in their jobs are more likely to either obtain or be enrolled in a master's or higher degree program by wave 3. We asked a qualitative question at the end of our survey: what are the barriers that prevented nurses to going back to school and obtaining an additional nursing degree? And almost 75% of our respondents answer the qualitative questions. So we have compiled and summarized the barriers. We only looked if respondents would list several barriers. We only counted the first one listed. So the most common barrier based on the qualitative results was cost, followed by family and or children, lack of time. 7.5% responded that they weren't interested in getting a degree, and about 5% thought they were too old to obtain an additional degree. In summary, by 4 to 5 years following graduation from the basic nursing degree program, we had 16% of our newly licensed registered nurses who were in school or have graduated from a nursing program in addition to their basic nursing degree. So those could be either nurses who had an associate degree and have graduated from a baccalaureate program, or those who had a baccalaureate degree and have graduated from a master's degree program. In addition, many respondents said that they plan to return to school within the next 12 months, almost 33%, or within the next 5 years. So going back to summarize the findings from all of our analysis, we can say that baccalaureate degree nurses thought in general that they were better prepared for quality and safety than associate degree RNs, but they did not necessarily participate in quality improvement activities at work more often than associate degree nurses. Again, some of the factors that we found impacted nurses completing additional education, a lot of them are not modifiable by employers or policymakers or nursing schools, but there were few incentives that could help with nurses returning to obtain additional education. In terms of the implications, there is a room for improvement in educating both baccalaureate and associate degree graduates in quality and safety competencies, and I would encourage both nursing schools and employers to utilize educational tools and resources that are offered through the Institute for Healthcare Improvement, or wonderful resources that are made available at the Quality and Safety Education for Nurses QSIN website. We also need to think about what is the link between having not just higher proportion of baccalaureate prepared nurses in hospitals, but also nurses who are capable and knowledgeable specifically about quality improvement, and how does that relate to improved patient outcomes. In terms of the implications for promoting nurses going back to school, increasing scholarships and other financial incentives should be the highest priority for funders. Also, developing educational policy that makes returning to school easier and more efficient, given the mainly off of our qualitative responses, that lack of time and also having to deal with family and children are some of the barriers for returning back to school. For employers, having flexibility with scheduling and allowing nurses to take night classes or have consistent days off may be something that can incent them to pursue higher education. And also forming academic clinical partnerships that mentor nurses or newly licensed nurses to return back to school. And that was really interesting, looking at those nurses who worked in ICUs, step-down units, and who had more variety in their daily work were more likely to pursue higher education. So having mentors and who can promote return to school may be one option as well. I would encourage you all to visit our website at rnworkproject.org, where we list all of our published work and where you can look at these findings in more depth. And I will be happy now to take any questions.
Thank you so much, Maja. That was fantastic. Just beautiful work and so on target in terms of informing our efforts to advance this important recommendation. And I know now I'm going to turn it over to Heather, who is coordinating, I know, what will be a robust conversation discussion of your very important work.
Thank you.
Thank you. Given the cost issue, Maja, that you were discussing, have you and your team given any thought to the impact that the proposed reduction in federal student loan availability, as well as the proposed increase in the interest rate on federal loans, might have in terms of the current positive trend in nurses obtaining higher degrees? Do you think that might decline as a result?
Christine Kovner has actually received additional funding from the Robert Wood Johnson Foundation to look at the cost of getting to the 80-20, and some of the preliminary findings. It is very costly, but I think we do need to look at not just how much it costs to get nurses to obtain additional education, but how much money is being invested in, educating physicians and allied health professions as well, who have at least for some, in some cases, doctorate as entry into practice. So I think, regardless of trends in interest rates, I think fundamentally it's maybe the value issue. How much do we value nurses obtaining additional education, and how do we decide to invest resources in providing support to physicians or other professions versus nurses to obtain additional education.
Great. Another question was, since those who work day shifts are more likely to obtain a bachelor's degree, are there ways that you might have discussed to encourage individuals who work night shifts to advance their education?
I don't think that, these at this stage we are just trying to uncover what predicts nurses going back to school. I think one intervention may be for, traditionally new nurses, due to seniority issues after the orientation period, work the night shift. So this may be one trade-off on part of organizations who want to promote education in their staff to, think about, be more flexible about scheduling and giving, maybe preference to people who are enrolled in baccalaureate or higher degree programs to work days until they're done obtaining their additional degree. So that's something I think for organizations to think about in terms of how they schedule newly licensed nurses.
Mm-hmm. Very good. Why do you believe there was no difference in the associates and bachelor's nurses' participation in quality improvement activities in the 04-05 licensee group?
So I can tell you that it was an issue of power in our sample. So it's interesting. We don't, really have a good answer for that. It may be that, it's definitely, I think, in terms of participation, characteristics of workplaces in which new graduates work. It's kind of counterintuitive to at least what I know here from the New York City area. I know that a lot of our hospitals who are magnet certified, almost exclusively hire baccalaureate degree graduates and work really hard to involve them in quality improvement. So I don't have a good answer on why, despite nurses' perceptions of being better prepared once they get to the work settings, there are no differences in participation at work, and maybe more the function of organization and less the function of their education.
There was a follow-up question, but the answer might be the same. What do you attribute to the statistical difference in quality improvement participation between these two groups for the 07-08 licensees? Or maybe the question is, did you see a difference between those two groups, the different...
Right. So we're doing some additional, and I'm trying to flip through the slides to find that slide. So, one thing that we hypothesized, the world maybe have changed between the 04, 05 licensees and 07, 08 licensees. There are several, at least, again, we need to think about what different policies are hospitals exposed to in the 3-time period. We know that CMS has introduced some new reimbursement incentives for hospitals collecting and participating in the NDNQI initiative. So maybe things that are happening in the policy environment that are impacting hospitals' requirements for collecting and reporting nurse-sensitive data have induced differences in our findings between the two cohorts. But that's one thing we have thought about.
Another question has come in. It says, in the original survey, were any organizational factors taken into account with regard to nurse participation in quality improvement? For example, potential motivation due to presence or lack of clinical ladder?
So far, a lot of our items pertaining to quality improvement participation are single item measures looking at different activities. So although we wanted to run some regression analysis to look at different personal and organizational factors that may predict participation in quality improvement, we did not find hardly anything significant in terms of predicting overall participation in quality improvement, and just maybe the function of the way we ask questions. So as of now, we have not found any organizational characteristics, for example, teamwork and collaboration, or autonomy or variety, or a number of work environment characteristics to be predictive of nurses' participation in quality improvement in our data.
Let me just tell you how tremendously grateful we are for the work that you're doing, for spending the time with an audience that is very interested in understanding the challenges and implications and possible futures associated with implementation of these recommendations, and to have that grounded in knowledge of what we know about certainly the current workforce and their engagement related to quality improvement, patient safety, and that culture is exceedingly important foundation against which we can measure future changes. So I thank you, Maja, for this tremendous presentation, for your work and your team's work, and I know that there'll be a lot who will be following you.
Thank you so much again for inviting me, and it was my pleasure, and I look forward to continuing this dialogue.